Now, Andrew, good morning. For everyone else that doesn't know me, my name is Sydney and I'm from the PHN education team. And before we begin, I'd like to acknowledge the traditional custodians of the land that we are meeting on today. For myself, that is Darkinjung land. And I'd also like to pay respect to elders past, present, and emerging. Now, Andrew has more than 25 years of experience, with most of his career spent in injury management of professional athletes. He is the owner and the principal of Aspire Physio in Erina, which has been operating for more than 8 years. Now, as you know, this is a pretty casual session, so we have the chat box. Please pop anything in. The recording will also be available at the end in our vertical integration library on the PHN website. If you want to chime in at any time, please feel free to turn your camera on, ask any questions. We just want to keep it going and let it flow organically. Before we get into Andrew's presentation, we're going to do a few icebreaker questions as well. So first one for you, Andrew, are you a morning or a night person?
I'm a night person, so I'm fish out of water at the moment. I set 3 alarms this morning to make sure I was here for this time.
Well, thank you for getting here on time. I was going to guess morning because you are here. Next one, favorite cafe on the Central Coast?
Oh, good question. I'm not a coffee drinker, so to be honest, I'm probably the worst person to ask. If someone comes to the clinic and wants a coffee, I've got to ask someone else how to do it. So, favorite cafe. I probably can't even give you one. I've got 3 kids and don't drink coffee, so I can't remember the last time I sat in a cafe.
Oh, that's all right. There's plenty to choose from anyway.
I wish I knew.
Next, I was going to say, which one would you get the kids a cookie then?
I don't know. One of the ones in Terrigal, there's a dozen to choose from. I'm not too fussy.
A fun fact that we don't know about you.
We were talking beaches before. Favorite beach would be North Avoca, and a few years ago, 20 odd years ago, we got married on it on a day that we were very grateful. Didn't rain and wasn't too windy.
Oh, beautiful.
So that's where we had our red carpet moment.
I was like, congratulations on 20 years of marriage as well.
20 odd years of marriage, yeah, almost been married as long as I've been a physio, and yeah, both have been a journey and still going.
And the biggest learning experience in your career to date?
Good question. I think you learn from your mistakes probably more than any other, and then you try not to dwell on them and remember them. But I guess one thing I always say to our team here is that we must learn something from every patient, because if we don't learn something from every patient, then we're not really listening and we're not really looking. And I think the day we don't learn something from every patient is probably the day to give it away.
Yeah, good answer. I like that. All right, well, I'll hand it over to you and you can get into it. Thank you.
Thank you. I'll do my best here. I've sat on the other end of this webinar phenomenon, but I've not been on this end of it before. So lots of buttons and screens and things like that. And it's a bit strange sort of talking to an audience that you can't sort of get that instant response from, to feel like if you have them engaged or you have them bored. So if you have any questions or I'm rabbiting on, then feel free to pop it in the chat box and slow me down and ask. I guess low back pain, as you know, is a common subject, and although I've spent probably 10, 12 years full time in professional sport, the majority of my career, I guess the other big half of it is just working with the general public, and I probably enjoy that more than anything else. The gratitude of your average patient that just wants help and seeing them recover and get better. And so low back pain is something that we see a lot. I'm just trying to make sure that my screen, here's my first glitch, and this is not happening. I'm just trying to skip my screen across, and I'll have to do it a different way. Okay, we'll do it this way. So I thought about, obviously as physios, we're familiar with seeing lower back pain, and GPs as are you. So I looked at some of your data to try and find out how common this is, and I was a little bit surprised. This comes from a survey of GPs from 2000 to 2015, and musculoskeletal presentations comprise up to about 14% of all of your consults. I'm very respectful of GPs. I think you've got the toughest job in medicine, having to know so much about so many things, but I'm pretty sure that most of you wouldn't have got into the game to deal with musculoskeletal problems. I could be wrong on that, but I dare say that's probably not your prime passion. So my goal today is to try to make something that you see more frequently than you probably want to, just that little bit easier. Of those up to 14% of your consults, the spine was nominated as nearly 1 in 5 of those. But there was also a big number here of other or non-specified, where the GPs that were surveyed just said it was something. And there's a fair chance that a good chunk of those would have been spinal presentations as well. Now, these are not all necessarily lower back, but lower back pain is going to be the majority. So lower back pain is something that's going to walk into your door or hobble into your door. Patient with lower back pain, it is common. It's going to be very common. And a little surprising to me, I think, as if this survey was done another 15 years and with generational change, I guess that people are more likely over time to present for primary care with a physiotherapist for lower back pain. But certainly over this 15-year period from year 2000 to 2015, these numbers didn't really change. So if you don't like seeing lower backs, the numbers of them aren't decreasing for you. So let's try and make it a bit easier. Up to 20% of people presented to a GP each year with some kind of musculoskeletal condition. The number in blue is one that, as a physio, jumps out at me a little bit, that about 30% of musculoskeletal consults resulted in some kind of referral for imaging. That seems to me a high number. So I know that, for example, we wouldn't, as physios, refer 30% of our patients with musculoskeletal presentations for imaging. I think part of that may be patient expectation as well. They may present expecting imaging, and so maybe more present to GPs for imaging than present to physios. But it's still quite a high number, and it's certainly something that's topical with regard to low back pain at the moment. We'll talk about shortly. Can everyone hear me okay? Just want to make sure I'm not talking to myself. I have a habit of doing that.
Yep, brilliant.
Cool, okay. All right, and so adult low back pain, it's not just a common problem, it's also a horrendously expensive problem. The second leading cause of disease burden overall in our country. It's an enormous cost, and if it doesn't already, it should certainly make us question as a health system, how well are we managing this? And I would say, on the whole, I think it's something that needs to be managed a lot better. It's certainly the subject of a lot of research. That research is oftentimes helpful and sometimes not. But it's certainly something we see a lot of that I think as a whole, as a team that manages this across the country, needs to do better. 1 in 6 Australians had back problems in 2017-18, which is 4 million people. That's a lot of people. 38% of those people reported that pain moderately interfered with their activities of daily living. And that's what people come to us with and would come to you with as well. Not just the physical pain they're experiencing, but the pain of missing out on what they need to be doing or what they want to be doing or what they should be doing. The pain's not just the physiological one. So to give you an idea, our caseload, we track this as well. 21% of our patients are adult low back pain patients. We have an additional 1.5% to 2% of our patients that are adolescents with low back pain, which I'll talk about as a separate group because they have different problems and I think they need to be managed very differently. And then another 1% with pelvis or sacroiliac joint type pain. So pretty much 1 in 4 of our patients are coming to us with some kind of pain between their SIJ and L1. So that's a lot of people. That's a lot of people that are walking in our door. We spend an hour doing our initial consultations here, and then we spend 30 minutes for our standard consults. We do average seeing patients 5 times after their initial consult across the board with all types of conditions, which means that a physio in our clinic spends on average 3.5 hours with every patient that presents with pain, and 1 in 4 of those patients are low back pain patients. So I'm not saying we see everything and that we know everything, and I certainly don't, but 25 years of that's a hell of a lot of time listening to people talking about their lower back and a lot of time trying to address that. So I'd like to think we've learned something about how to do it better in that time. When patients come to us, they probably come to you with the same needs and questions. And this is a subject of research amongst physiotherapists, trying to make sure that we're servicing our customer base, our patient population better, finding out exactly what they want from us. Because if we don't deliver what they want, then we probably won't get the opportunity to deliver what they need. And certainly they present with essentially 6 questions. I'm just going to go through this because I think it's important that we understand why our patients come to us. As far as knowing about their injury, if we don't listen to them, if we don't do this part well, they're going to walk out the door and go to another practitioner until someone does listen to them. The first question that they have is simply, what have I done? They do want to know what they've done. They do want a diagnosis. I think it's important how we phrase that, what we call that. I think it's important that we pick our patient well, and we don't use too many big words or lingo that doesn't make any sense to them. But there's certainly, varying levels of health literacy across our patients, and I think we do become pretty good at working out who can take the big words, who needs to hear the big words, who doesn't want to be patronised with just very general, dumbed down language. But people do want to know what is wrong with them. They do want a label. And as a patient, when I've been a patient as well, it's important because the label often drives the treatment path. What you're diagnosed with opens up the access to the type of help that you need and what's available. The pathways tend to follow. So what have I done as the first question? Why is it there? Most people want to know, why me? Why do I have this? And as physiotherapists, addressing contributing factors is often that's where the prevention is. So we may need to address today's problem, the patient's pain that they hobble in the door with, but addressing prevention, which is always our final goal, is something we have to know what the contributing factors are in their world, because if we don't know what they are and we don't change them, there's a very good chance we're not going to prevent recurrence. And we know with low back pain, recurrence rates are extremely high. They may be high regardless of what we do, but they'll definitely be high if we don't address contributing factors. They want to know, can you help and what will you do? What is the physio's role? And I would think for a GP, they want to know, what can you do to help me? What will you do? I think there's been a big change in physiotherapy over my time away from passive, they were called passive therapies. I'm not sure there was much therapeutic about many of them, but there's definitely been a shift towards activity-based rehab and active exercise, and the patient having to have a role in their own recovery. That doesn't suit all patients. Some people just want to be fixed. Some people want you to fix them. And there are definitely things that we can and should do to relieve pain, improvement, and get them going. But the physio's role is certainly one of making them understand that there are things that they need to do to help themselves. Then that leads obviously into the what do I need to do, the patient role. We need to make it pretty clear with our patient what we can do to help and what they need to do to help themselves. And we have an expectation that they do that. And it's our job to help them understand why that's necessary. And if we don't do that bit well and they don't do it, then that's on us as well. They have come to us for help. If we don't get that across, then that's a skill that we're lacking, and that's something we spend a lot of time on trying to make sure we get right. How long will it take? They do want to know how long it's going to take to get better. Just like the patient, the footy player that hurts a hamstring, the coach says, how long till he's back? 4 weeks, 3 weeks, whatever the answer is going to be. People want to know how long they're going to be in this pain. And in my experience, pain is something people can tolerate far better when they know why it's there and when they know that it's temporary and it's going to go away. Pain that's unremitting and unexplained is confusing, daunting, confronting for people. And I think if we don't answer these questions well, I think we do potentially set them up for some of the psychological problems that we do know promote ongoing or persistent pain presentations. And then the final thing is, how often do I need to see you? What is the dosage? What is the dosage of treatment that we need to deliver, the intervention? And so I'd be surprised, I'm not familiar with any studies about GPs and what patients present to you within their mind, what they want to know. I'm sure those studies are probably out there, but certainly for us, the low back pain patient or the musculoskeletal presentation patient, this is what they are, this is what they want to know. And I'd be really surprised if with a musculoskeletal presentation it's overly different. Although I think generationally there would be probably more of an expectation on you to do something for them or to give them something, be it a referral or a medication. I hope I'm not being too simplistic there, but when patients come to us having seen their doctor, that's generally what they tell us. I guess we summarise that down to a bunch of things that we talk a lot about in our clinic. Our patients, they want to be heard. And I understand the challenges in the GP world of time pressure and the time pressure of and the economic pressure of running a practice. When we spend 3.5 hours on average with our average musculoskeletal presentation, I don't know if our low back pain patients see us any more or less than that. We don't have those figures, but it wouldn't be any less, I wouldn't think. They want to be heard, and there's not a lot of time to do that in. In our initial consultation, we want to make sure that the to be heard box is well and truly ticked and the patient feels like they've been able to get it off their chest what they want to say. Then they want rapid pain relief. They want to feel better. And that's where our role's the most important part of our role is generally where we're using our hands. That's our manual therapy to try to ease pain. And even if we completely accept that that's only going to be a short-term relief of pain, a short-term relief of pain to enable somebody to do the things that they need to do to overcome their pain longer term is absolutely time well spent. And when the patient arrives wanting rapid pain relief, but needing to improve movement, improve how they sit at work, improve their activity levels, if we don't deliver what they want part, they won't come back, and we don't get to do the what they need part. So if delivering what they want for half an hour on day 1 or day 2 or day 3 is simply a bridge to have the opportunity to deliver what they need, then that's time well spent. They also want to plan. They want to know what they need to do, and that's something we spend a great deal of time explaining to them and also making it really easy for them to follow. Once a patient walks out the door, we actually have very little to no control over what they do. We've had the time we've had to talk to them to earn trust. We've had the time to spend using our hands to try to make them feel better. And hopefully, as a result of that, they believe in us and respect what we do. But once they walk out the door, unless we have some tape attached to their lower back, which makes it more difficult to bend or slouch, to limit their position or movement in certain directions, we actually have extremely little control over what they do. So if we don't get the bit right in the consult room and influence what they do when they leave, we're completely at the legacy of them for our outcome. We can't, for a very simplistic example, if a patient presents with a strep throat and you prescribe an antibiotic, you can be confident in the outcome provided they take it, but taking it is very simple and easy and very little effort, whereas often what we're requiring the patient to do is more time consuming and requires a lot more effort. And so we've got to convince them of the merits of what we need them to do. But they want to be listened to and they want to be talked to. So I think it was important just to explain that, because that's the position we come from with our patient. In terms of the clinical bit, and this may or may not be more what adult patients have. There was a term adopted in the research which you read everywhere, non-specific low back pain. And I've put a big line through it. It's a term that in clinical practice we have to be respectful of. We're respectful of the research. But as you would know, when you call all patients the same, we know that they're not. And so non-specific low back pain, if you look at the research for different types of treatment approaches and different outcomes, most of the research is fairly poor in terms of the effect that we have. But I think in the clinical world, we should and we do better than that, because patients aren't all the same. The listening bit and the talking bit, the bit I've just spoken about, that's stratifying your patients into different categories of what they need, what they have, how they behave, how they think, what they do for work, what they do in their life. With so many variables at play, we can't call patients the same. No two patients are the same, let alone systematic reviews that collate tens of thousands of patients. So I think that the label that the patient is given, or the explanation that's given for why they have their pain, is very important. And I think explaining that well is an important skill. And I often say to our younger physios, how you push on someone's back is probably not going to change a great deal over the next 20 years as you work, going from young graduate to old hand. But I can guarantee how you explain things to people absolutely change. That's where your biggest room for improvement is, and that's where our biggest skill set is. So the label and the diagnosis definitely matters, and I think we can do better than just calling them all the same. And I'm sure you don't want me to say that, non-specific low back pain, this is what I suggest you might consider and what you might do, because that's not very helpful for you either. With the age, I've put that age arrow there because over time with age, the likelihood of different presentations changes. The majority of younger adult back pain, and I'm speaking in fairly general terms here because we've got a relatively short time to discuss a subject which I've probably spent 6 or 7 of my clinical years actually treating. So it's a huge subject with a massive body of research, but I'm trying to simplify it in something that's useful. Most systematic reviews of non-specific low back pain for clinicians are not useful. So let's sort of break it down. The intervertebral disc provides the majority of the low back pain that you'll see in adult patients, probably from late teen, early 20s up to 40s, 50s, and maybe even into 60s. As we age, the disc changes, and when we're older, it is less likely to be a pain generator. In that early stage, it is probably your most likely presentation, and it's a term that instills fear in patients. Disc just sounds like trouble. And so what I'm saying to my patient has with disc pain, look, your pain is probably coming from one of your lower lumbar discs, L4-5 or L5-S1. I can't touch it. It's too deep inside. It's protected by a cage of bone. But based on your presentation, that's probably where your pain's coming from. And don't be worried about that, because that's where the majority of people in your age group's pain comes from. And the majority of them do very well and get better in a few weeks. So we're trying to decatastrophize the terminology from the very outset. But if we don't use the terminology, they'll walk out the door and think, oh, they've just given me a simplified, dumbed down, patronising explanation, or they don't know what's wrong, even worse. So we do have to use some words, but we've got to be careful how. And then lumbar facetogenic or facet joint driven back pain, as one gets a bit older, gets a bit more likely. We don't see a great deal of that in younger people. In the younger people that we do see that in, they're probably more likely to be sporting kinds of people, or people that do more activity that goes into lumbar extension. Then as one ages or matures, then problems like a spondylolisthesis is present in 5 to 10% of the population. That doesn't mean it's symptomatic in that many of those people. It's not. But as people get older, it's more likely that slip starts to slip further, and it's more likely to become symptomatic. So the patient that's having a fusion typically is having it because something's treading on something that it shouldn't be, like a nerve, and a spondylolisthesis is a considerable cause of that in people probably more likely 40, 50, 60. And then I sort of say to my patients as they get me, oh, look, your holes for your nerves get a bit smaller. And so we have a model of the spine in all of our consult rooms, and we'll show them the little yellow nerve root exiting the foramen. And as we get older, joint surfaces thicken, joint ligament tissue thickens, ligamentum flavum on the middle thickens. And so the little conduits, I use analogies like if you're an electrician and it's a wire and it's a conduit is the pipe that it comes out, the pipe starts to get a bit too small and can start to strangle the nerve. And a canal stenosis in an older patient, like you're not going to see a canal stenosis in a 20-year-old, but in a 70 or 80-year-old, it's a much more likely diagnosis. And then there's the things that can happen sort of at any age that are a little bit more intense in their pain, often like the radiculopathies, which are, nerve pain's more intense. It's a different pain. It's a horrible pain. That's a different thing, often caused by most likely a disc injury, that younger adult. Cauda equina syndrome, the patient that presents with saddle paresthesia and loss of feeling and bladder and bowel control. I've seen 3 patients in my clinical time present with cauda equina syndrome. And I certainly remember the first one. He'd been to hospital twice and sent home, and he was carried in with an ataxic gait. He looked like a footballer who'd been hit in the head. He was being carried off the field between his dad and his brother-in-law. And he had classic textbook cauda equina syndrome. I think I was a new grad. I thought I'd never see it. I remember ringing a neurosurgeon in Sydney saying, I've got this guy. I think this is what he's got. What should I do? And he said, tell him to pack a bag and come straight to North Shore Hospital. And he had surgery that night. So those types of patients, although uncommon, they do present into our practice. And the 2 other cauda equina syndromes I've seen, the red flag box is typical. They had metastases treating on their cauda equina nerves, and their presentation to the physio is what led to the presentation to the doctor, which resulted in their unfortunate diagnosis of their relapses with their cancers. And obviously, once it gets to that stage, the end's not far away. And I remember going to one of the funerals of those patients. So we do see people rock up with very benign low back pain that may not be that much an effect in their life. And then we do see people at the other end of the spectrum as well. So with that acute discogenic pain, if somebody they may have bilateral pain, if they have bilateral pain that's acute in onset, it's very likely that they have discogenic or disc-generated low back pain, because the disc is the only structure that's in the center that can send pain left and right at the same time. If they have a pain that is causing what we call a side list, that patient that presents, I know you can only see the top bit of me, but with their hips to one side and their shoulders to the other, that the great big muscle spasm that pulls them across, which we call a side list, they almost certainly have some kind of disc pain presentation. Disc pain typically responds to movements and positions, both feeling better in certain directions and feeling worse in others. Typically, your disc patient will present with more pain going into flexion. They don't like sitting, which for many people is a position of flexion, because as you would know, the lordosis and the shape of the human back is usually very different to the shape of the back as it is sat in a chair. And for many people, sitting in a chair is how they position themselves to make their living nowadays. So the patient that presents with their pain aggravated by sitting, that doesn't like flexion, that is worst in the morning. Most sore backs are a bit worse in the morning. There's not many back pain patients that say morning's my better time of day, but for the disc patient, it is usually markedly a worse time of day. And then things that result in sudden changes in their intra-abdominal pressure. So to cough or to sneeze, initiate a movement, if they're lying on their back to try to pick a leg up or to pick something up, those types of activities usually result in a sudden change in their back pain. Our first goal is to try to find a position of relief for them. Most of these patients, when they've not experienced this before, they just don't know what to do. They don't know whether to sit, to stand, to walk, to be still, to stay in bed, to get out of bed. This is certainly something that's changed a lot over my career time, and probably yours as well. Bed rest is pretty much out, but there are patients that do need to get off their feet for a time. When they aren't on their feet, there is less longitudinal up and down pressure on their lower lumbar disc. And for many patients, being off their feet is a big source of relief in that acute phase. So just because bed rest is out doesn't mean that non-weight bearing in its entirety has to be out. I think when we say bed rest, it just sounds prolonged. And most of these people are better doing things for shorter periods of time. So walk, like little short walks. Don't walk for half an hour if after half an hour you're walking worse than when you started. So our general advice is, I want you to go for a little walk, but you must walk back in the door as well as you walked out of the door. Otherwise your walk was too long, and it's not helpful if it's aggravated your pain. There's times when we prescribe exercise that we know is going to be painful at the time, but we're confident there's going to be good benefit from that. If walking's making them sorer, then they're walking too much in that early phase, definitely. So we want to know what their positions of relief are. Most people will have what we call a direction of preference. They prefer to go either into flexion or away from flexion into extension. As a general rule, our default sort of starting point with a patient with disc pain is usually to take them into extension, because in our assessment, they've usually demonstrated to us that repeatedly going into flexion makes them worse. And clinical reasoning often just means simple logic, and logic to us is reason to other people. And if someone's worse going forward, then we simply start with, well, let's go the other way and see what happens. And quite often that radicular or that referred pain, our goal is to centralize that pain. The further the pain is referring from its source, generally, the bigger the problem. And so as their pain centralizes, we see that as improvement. They may have a short-term increase in the intensity of their proximal pain, but if their proximal pain is temporarily increased, but their calf pain has gone, or their pain doesn't go down their leg as far, absolutely that's improvement. And that's something we've got to get across them very clearly, that not just their intensity of pain is of interest to us, but how far their pain is referring is an important indicator of recovery. So if a patient comes to you and after 5 days of being in intense pain and they see you on day 5 and they're like, my back pain's now worse than it was, and you say, okay, but where is your pain? And they're like, yeah, it's worse in my back, but now my foot doesn't hurt and it only goes as far as my calf. You can be confident and say to them, that's a good sign. I know your back pain's a bit worse today, but that will pass, that will ease. It's a good sign your pain's not going so far. So hopefully that's something that's helpful. But we need to put the patient in control of their pain, and we can do that usually by putting them in control of their position and just simply educating them about where they're most likely to feel better and doing that within our consult session. So they're not just taking our word for it, they've done it, they've experienced it, and they know where to put themselves or where not to put themselves. So in one slide and one explanation, that's probably the most common presentation you're going to see. But I'm just going to quickly bring this study up as well. 2015, this is a big landmark study that basically showed that spontaneous regression of a lumbar herniated disc is possible. And it's not just possible, it's very probable and very likely. As MRI has improved, we've been able to take better pictures of what's going on and take a picture of a patient when they're in acute pain, and then at 2 weeks, at 4 weeks, at 6 weeks, and 3 months onwards, etc., and see how it recovers. There was a perception, and it was probably only perception because we didn't know, that once you had a big disc injury, you had that problem for life. When I started as a physio, that's what we thought. That's what my understanding, what the medical world thought. That disc pain the disc didn't have this healing capacity. We all know if you split your lip, there's lots of blood, lots of pain, lots of healing. Within a couple of days, it's better. The disc was considered to be the opposite of that. This study's shown that absolutely not to be true, and it's a hugely reassuring source of information. Rate of spontaneous regression, disc sequestration, a piece of disc that's come off the rim of the disc, 96% of these go away. This study wasn't about what happened, what type of treatment was delivered. It was just tracking these patients with imaging as they recovered and taking pictures and looking at what it looked like. So while I'll talk a little later about, we know how common disc findings are in asymptomatic patients, disc findings of considerable significance in the acute phase do change. What's also important about this, and I know that's been up there for long enough for you all to read it, is that the bigger the disc finding, or the so-called worst finding, the higher the rate of spontaneous regression. And so the bigger words on the MRI report, and maybe the bigger pain at initial presentation, doesn't confine that patient or mean that patient is going to end up with bigger problems. And often that's not the case. They may be worse up front, but their chances statistically of simply resolving with time are better than the patient with a so-called smaller disc injury. Now, we could talk all day about why that is, but I suspect the body deals with it more intensively. The body devotes more resources. I think when the rim of the disc physically comes apart and the nucleus pulposus, the pressure can be released, I think the patient with the annular tear or the disc pain that's more minor often is more stubborn. The patient with a more minor pain is less likely to devote as much of their time, their own resources, to address their problem because it's not as big a problem. And it's a little bit like the low back stress fracture or the shin stress fracture takes longer to heal than the snap tib fib in the football tackle takes to heal. The bigger, more traumatic injury benefits from a bigger and more devoted response to heal from the body. So this is a study that I quote often with a patient that presents with the really big findings. Now, sure, there is a proportion of these people that are going to need the help of a neurosurgeon if their problem isn't in that. So the 4% of people that don't have regression of their disc sequestration might be stuck with a disc that's treading on their L5 nerve and they've got a foot drop. And that has to be dealt with. And it has to be dealt with, I think, fairly promptly. A foot drop in an older patient is not something I'm just waiting to see what happens, because we know the consequences of a foot drop with falls risk and mortality following that as people get older. We all know what happens there. So I think that there's definitely a proportion of people that do need that quick help, but on the whole, they can simply wait and have some time. And our role really is helping them cope with that time far better while we're buying time for nature to do what it's going to do. So just a couple of examples of MRIs. I know that within the limitations of a GP consult, you don't have the time to go looking at a whole heap of pictures when you're seeing so many as you are. But when I look here, I don't know if you can see my mark. No, I don't think you're going to, but that's a pretty substantial disc bulge. The big round bit in the middle is the disc, and there should be like a little triangular white part of the cord, and you'll see the top left-hand corner of that little white triangular part in the middle of the screen is blocked out by the black. That's the disc that's treading on the nerve obviously that's the right side of the patient. And then when you see in the sagittal view, that's a pretty substantial looking disc bulge. This was one of our patients a few years ago. This patient presented with very intense low back pain. This patient had no calf power, so that's the S1 nerve being trodden on, and could not do a calf raise, could not stand up, or a heel raise, could not stand up onto his toes on that foot at all. This patient had intense radicular pain shooting down the leg. There was some localized paresthesias and pins and needles in the foot and leg. This patient completely recovered. Now, when this patient had the MRI, which they'd asked for, and considering the presentation, I was happy to give a referral for that. They see this picture and they're like, okay, so what does that mean? I need an operation. I said, it means that you need an operation if in a couple of months you're not better, but you don't need it right now. If you can put up with your pain, and we would have probably asked the GP, referred the patient back to their GP and said, is there some way we can relieve this person's pain, please, with pain medication, and maybe your neuro type medication, the amitriptylines and Lyricas and things like that. I understand that they're complicated medicines and we don't prescribe them. We just ask the patient to ask you, and you knowing their health world, whether that is something that is suitable for them. If that allows them to tolerate life a bit better so that their disc has the opportunity to heal, that's what we're asking for. But this patient got better. The next picture is a disc injury that looks pretty similar, looks really similar, and that's what I was looking for. Two that pretty much did look close to the same, but what was different were their pain presentations. This patient had almost no low back pain. He had no calf power either. He couldn't do a calf raise either. He had more calf pain than he had back pain, but it wasn't too bad, but he was really tingly. He had a lot of paresthesia, and he also 100% recovered, and they were treated exactly the same way. And so while the imaging may have looked similar and their initial presentations had some factors in common, no two patients are ever the same. If the patient is a L5 rather than S1, and it's a foot drop rather than a weak calf, people can live with a weak calf. If they can't push off properly, that may not be much of a problem. The scan on the left, that was a guy who was probably 35, 40, and he was a runner. He ran 400-meter races, and so calf power was really important to him, but he didn't want to have an operation he didn't need, and he was happy just to give it time. I think we may have booked an appointment with a neurosurgeon, which we were going to wait 2 to 3 months for, which at the time sometimes seems inconvenient, but that 2 or 3 month period is a time that should be given to pretty much all of these patients to see if they get better anyway. And so by the time their appointment rolls around, they're either better or they don't need it, and they can cancel that appointment. And I know the neurosurgeons have got more patients than they can fit in, so someone's going to take that spot. So sometimes we will preempt the appointment thinking, okay, there's a few flags here we need to look at. Let's have plan B organised, and we explain that to our patients so that a couple of months down the track, if it hasn't gone how we hope, we're not sort of backpedaling going, oh, that didn't work, let's try this. They need to know that we've got different options available up front, and we're giving them the choice to be involved in the decisions that are made with them and for them as well. I think that's really important. And then there's your facet joint pain. If somebody has left-sided facet joint pain, left-sided facet joint that's generating pain, that cannot give them right-sided low back pain. So facet joint pain can be bilateral, but if it is unilateral, then it is probably more likely that a facet joint is generating that. So discogenic pain can be unilateral, definitely, often is, but a facet joint that's sore can't give you right-sided pain. They also don't get central pain. So the pain that's right in the middle. Facet joints aren't right in the middle, they're just off to the side, but the patient that has pain that's right in the middle and then spreading, or right in the middle and then spreading to one side, that's a different presentation than the facet joint pain patient, where the pain is usually just off to the side, and they're usually worse into extension. They have generally speaking, they have a different pattern of movement that bothers them. Our role here is to try to get that painful joint either to move more or to move less, if that's the level at which what we call them hinging. If somebody leans backwards or when they're running, their movement is not evenly shared throughout their lower back, and they're very stiff, for example, from L2 to 5, but L5, S1 is where they're doing all their bending. That's the joint that tends to get cranky and stiff. But if that's where they're doing all their bending, it doesn't make much sense for us with our hands and thumbs to try to make that joint more mobile. often what we've got to do is make the joints above more mobile so that that painful joint is not bearing the load of all of the movement. These patients do need manual therapy, and they usually respond well to that when we can achieve what I just explained. But there are times where our thumbs might provide short-term relief, so we know we're on the right spots, but we're not able to provide sustained relief. And that's where a facet joint injection, if we can identify that as the source of their pain, or we can be confident that's the source of their pain, then there might be a letter coming your way requesting consideration for a facet joint injection referral, please. If we've identified the pain source accurately, then they are usually effective for short to medium term pain relief. And if we've hit the spot well and we've been able to address the contributing factors, we all know cortisone is a short lasting thing, but for many patients, we just need to break their cycle of pain and the pain won't come back. Bone scans are often done to try to identify which is the active joint. Sometimes they're helpful and sometimes they're not. Generally, in a patient that's getting a bit older, we'll find other spots that are also lighting up on the screen that are asymptomatic. And in terms of which joint to inject, it is, I'm not quite sure what you're all taught, but it's my experience that it is not always the case that the joint that lights up the most is necessarily the sorest. And I generally trust my thumbs to say, let's do L4-5, please, rather than just the bone scan. And I can't remember the last time I ever asked for consideration of a bone scan with a view to an injection. I'd avoid the radiation, and there's not that many joints to target that I think make a bone scan necessary in most cases. And there's your spondylolisthesis, which is where one vertebrae slides forward on another. As you know, generally these patients like flexion and they dislike extension. They're usually happy to sit, happy to slouch. And when they're relatively stable and happy, they're usually happy to forward bend. They vary hugely in how people cope. You see some people that have a spondylolisthesis that's huge and yet they function with no troubles at all. And you see other little ones that have considerable trouble. We obviously only see the symptomatic ones. So I can't tell you that much about all the asymptomatic ones because they don't come and see us. But this is something that obviously is not going to heal, and we're teaching them to self-manage. But if they're on that slippery slope towards instability, I'm usually pretty open and saying, okay, there's two things that can stop this vertebrae sliding forward on the other one if we're confident that's what's causing their pain. We've got the muscles we can train that I can teach you, or you've got the metal that a fusion and a surgeon can give you. The muscle option's usually pretty attractive to most patients, and it's enough of it's not a threat, but it's plan B. And if plan B is unpleasant enough, then plan A all of a sudden starts to look pretty good. And with the facet joint needles aren't a lot of fun. I've had a lot of facet joint injections work pretty well before they happen too. So the placebo of a facet joint injection sometimes can happen before the injections happened. Just the mere thought of, oh, this is what plan B is, can turn a 4 out of 10 pain into 2 out of 10 at times. So that psychological process that we're going through with our patient is very important. And then as people get older and those holes get smaller, there's the foraminal, the canal stenosis presentation. Often the distal symptoms are worse than the proximal. This is that patient that shuffles along the shopping centre for 200 or 300 metres and has to then sit down. And as soon as they sit, their pain completely goes away. And then they can get up and go for another 200 metres. We can't fix canal stenosis. We may be able to teach them what to do to provide relief. But if the patient has a true central canal stenosis that is very, very limiting for them, then surgery is the only thing, in my opinion, is going to fix them. And for those patients, it's typically a great operation because they get their life back, they get their activity back. So in that patient, we wouldn't be delaying. Seeing a patient with canal stenosis is often followed by a letter to a GP saying, could you please consider referring this patient on? So I know I'm rabbiting on, time's getting away. You will get these slides later, but you've probably seen the studies showing how high the percentages are of so-called abnormal findings on lumbar spine imaging in healthy or pain-free subjects. We shouldn't call these findings abnormal when they're in the majority of people. If something's in the majority, I'd say that's probably more likely to be normal rather than abnormal. But in radiological terms, there's lots of big words that are attributed to these so-called normal findings. In our experience, a lot of patients that come to us have already had a CT, and in the age of MRI, we tend not to rely on CT too much. I know it's easy and it's accessible and it's usually bulk billed, but in our experience, it's often not that helpful. In the patient that needs an MRI scan, we'll often give that referral if that's necessary, because it's going to cost them the same amount of money if the referral comes from us or comes from you. So unless we've asked them to see you anyway, we'll just organise the scan, and people are more expecting of that now. They're asking us for that more now, but we're not going to spend their patient money without good reason. I'd rather them spend their money on what's going to help them. And our rule with imaging is it going to change what we do with this patient? And if the answer is no to that, then there's not much point having the picture. But if they do have a picture, we do have more time to translate and demystify and explain what those big words mean. And it is always unfortunate when that medical language, which sounds severe, is interpreted or seen by the patient before we get the chance to explain it, because it is intimidating and it basically deters them from exercising, and exercising is ultimately what they're going to need to do to get better. So when we're talking to our patients, never underappreciate how much they will listen to you. They have come to you for relief and advice, and please try to remember, and we talk about this amongst our team all the time, that the language that we use is powerful. Throwaway lines and cliches do have people will latch on to small phrases and small words. Sometimes they want to latch on to what is better for them, and sometimes they will want to latch on to the label that makes them sick. And reassurance and recommending movement is advice, and it may be all you have the time to deliver, but that in itself is not just treatment. So please remember the impact of what you say is so big. Despite that other slide saying how common asymptomatic findings are in imaging, that doesn't mean that a condition being common is something they should just put up with or will just go away on its own necessarily. So imaging is usually unnecessary, but diagnosing and categorising the condition is usually a clinical diagnosis, and that is necessary. And imaging findings that are common in asymptomatic people doesn't mean that they're all irrelevant in patients that do present with symptoms. And I guess that's our job, that's our skill set, to try to work out which of those findings are the relevant ones for that patient. And quite often on MRI scan, we'll be going, ignore that one, but this is you. This is the bit that we're dealing with. And I'm saying ignore that because it's not causing you any pain. Don't worry about it. So manual therapy, there is evidence for manual therapy in the early phases of acute low back pain. And I guess what I'm saying is that while our goal is patient independence, there are times when people need a little bit of help up front. We don't want chronic patients. I think there's probably a misconception. There's probably a generation ago, both in GP world and physio world, chronicity is bad for business. If patients are coming to us on and on and on and on, and they're not getting better, there's nothing worse for our practice than that. Patients saying that I went to Aspire and I didn't get better. We want our patients better, and we want them better quickly. And I'd much rather see another patient they've referred because we did a good job with them than see that patient on and on and on. We want our people to be better. With referring, I think the language and the tone that you use is so important. There's a local orthopaedic surgeon, I won't say his name, but you'll all know him. And when he refers to us, and I'm sure he refers to many different physios, those patients come to us thinking that we're the best thing since sliced bread. If he says, go to Aspire, go and see Andrew, go and see Matt, go and see Dave or Patrick, the patient arrives with such confidence in us and such respect for us because of the way we were spoken about by the referrer. It makes such a big impact on the respect that they have when they walk in the door, and therefore we don't have to spend time, not that we're trying to spend time impressing them, but if they trust us immediately and believe in us straight away, it is just so much easier to get to work with what we need to do. So if you're going to refer, please refer earlier rather than later. And a line like, well, look, if you know better in a week, then go and see your physio, or go and see a physio. Whilst that, I think, is good advice, how you say that makes a big impact on the trust that patient will have with their physio. If you're referring to someone in particular, I'm not saying to give me or our clinic a rap because my ego needs it. I'm saying our patient needs it, and our patient will respond to that. We do know and respect our scope. If somebody's not responding as we would expect within 3 sessions, we are going to be doing something different. We're going to review that case. We're going to refer on or refer back. So we do stay in our lane, but how that patient walks in our door in their mind makes a big, big difference, and we'll always get back to you. Kids' low back pain, last thing I want to talk about. Kids and adults are different. Kids' low back pain is different, and the top line is important. Adolescents who experience more than 30 days of consecutive low back pain are 4 times more likely to suffer chronic low back pain as an adult. The very second or third slide I showed that back pain is the second disease burden in our society. I think is set up by that top line potentially. So chronic low back pain, we know it's expensive, we know it is hard to fix, and if kids have more than 30 days of back pain, we're setting them up for that in adult life. Their most likely presentation is bone stress or bone overload whilst they're growing, and most people, the most active time of their life is in their teenage years. If you look back at what you did as a teenager compared to now in terms of sport and play, it was probably hugely greater than now. Probably. I hope it's not, but the reality is it probably was. And so when you add the activity of life and sporting activity workload on a growing spine, fatigue fracture or stress fracture, bone stress, bone edema, resulting in a pars interarticularis defect. The defect is when it is an established non-bone union. I think we are creating a lot of our low back pain as adults and a lot of our disease burden that as taxpayers we're all trying to fund. And so identifying these patients is actually remarkably easy if you know what you're looking for. They present with low back pain and they often present to doctors and they often present to us as well. If they are particularly boys more than girls, if they're younger rather than older, if they're growing quickly and they're very active, you do see the exceptions, of course, where the kid that just sits all day and plays his games may get the same back pain. Achilles pain happens in 20% of people that don't run at all. So we don't quite know that, but it's much more likely in the people that do run around. These kids need to have their problem identified and they do need rest from their activity. So because the management is so different, we do need to diagnose them properly and promptly. They're also slow to get better. The average healing time of that bone defect or that bone edema is 18 weeks. So that's a long time. And that's a long time to tell a 14-year-old sports mad kid not to play sport. But if we don't do it and that bone stress becomes a fracture, and if it becomes bilateral, which happens in about 20% of them, they're the patients that become the spondylolisthesis patient down the track. They're the 40-year-old that needs a fusion. That's the very active patient that should be at an active stage of life having major back surgery. And if they're identified better, then that shouldn't happen with anywhere near the same rate. Please let us see these kids. Identifying this problem is really simple. These are the kids that do need an MRI to the extent that the government will actually pay for it. So if the government's offering to pay for it, there's obviously a good reason for that. They don't spend money up front unless they think they're going to save money down the track. So the patient that is 15 years or younger that has unexplained low back pain, which is basically every patient that has low back pain until it is explained, potentially has this pathology. And the only way to rule it out is with an MRI scan. The MRI doesn't cost the patient any money, and I'm completely respectful of the GPs and the doctor's role as defender of the public purse, and we've experienced some GPs that defend that very rigorously, and as a taxpayer, I'm grateful. But as a physiotherapist that knows what goes on if these kids aren't identified properly, we will politely, with a fairly detailed letter, ask you to consider referring these kids for the MRI. These are a different patient group to the adult patient that almost certainly doesn't need one. I put this slide together probably last year and updated a bit of it. We would have had 150, 200 of these kids in the last 5 or 6 years. When we're referring these kids with these presentations for an MRI scan, over 80% of them come back with the bone stress and defect that we're suspecting. So it's not you might have this, it is you probably have this. If they don't have it, they probably have just got some facet joint pain, need some manual therapy, maybe some modification of activity and a few exercises, and they usually get better very quickly. We're not shutting them down for 18 weeks. So we do need, because the management's so different, we do need to know whether they have this or not, which is different to the most common back pain patient where we don't really need to know if it's a disc bulge or a disc herniation. We just need to know how to manage them. So this is what they look like on a screen. The bright white is really obvious. Normal bone on these types of images is black and boring, and bright white is usually a bad sign. This was an 11-year-old kid. He'd had 10 weeks of pain. When we saw him, he was getting worse and still playing, and it took a long, long time for his day-to-day pain to go away. He was in pain just with normal daily activities, not sport, once we stopped him for 10 weeks. He saw for a long time, and he was playing for a long time before we saw him. So he's already in that adult low back pain likelihood of chronicity. Aged 11. Here's another one. This girl was a bit different. No active bone stress, but permanent defects where the green arrows are on their right of screen, this patient presented with calf pain. A 12-year-old didn't actually recall having back pain prior, but she had ability to calf raise and normal ankle movement. So she had calf pain with no sign of a local calf injury, but leaning backwards brought on her calf pain. So she's got chronic pars defects that won't heal. She's a spondylolisthesis of the future, and her calf pain took 8 weeks to go away in day-to-day life with treatment and activity of modification. So they sound like pretty benign things, but they're pretty persistent pains. So I'll just put this up here, not to read now, but whoops, for later. There was a study done recently by some former colleagues of mine that are involved in Australian cricket, basically presenting the argument in response to the big Lancet paper that you probably all had put under your noses, which emphasised the minimal role of imaging for low back pain in adults, which I completely agree with. But I guess what this paper is saying, but just remember the kids. The kids are different. SIJ pain, just quickly, it is that joint just below L5. This is a trickier one to treat. It is far more likely to be a unilateral pain. Some people do get bilateral SIJ pain, but much less likely. It often overlaps with low back pain, which makes it tricky. A lot of times patients will say it goes out, or have been told it goes out. That's rubbish. It does move. It's got about 2 mils and 2 degrees of up and down movement and rotation. There are clinical tests that are reliable to tell us if they have this pain or not. It's less likely to self-resolve because there's nothing really to heal. We need to make the joint behave differently, feel differently, and be more stable generally for the pain to go away. Particularly your pregnant lady who starts to develop lumbosacral pain, SIJ pain is a likely diagnosis, and they may respond to a pelvic belt and some treatment. And prototherapy is another option we have for the more chronic SIJ pain patient. So I know I've spoken for probably too long, but I hope that what we've talked about is helpful in your day-to-day practice. That was my goal. Remember that adult low back pain is different to kids. The adults almost certainly don't need imaging as a first course. They probably have disc pain. The kids probably don't. And if you need our help, that's where we are. If you've got any questions, then I'm all ears. Thanks for listening.
Thanks, Andrew. We did have one question come through.
Yeah.
So I had a 37-year-old man with numbness in the right foot, right calf, and low back pain. CT showed mild L5 S1 disc prolapse, 15 sessions of physio. So I'm trying to scroll without it saying Mobic. Sorry, I can't read it. And it didn't help. He referred him to a neurologist, and he diagnosed chronic inflammatory neuropathy.
Yep. So what I'd be saying, I'm pretty sure we didn't see the patient because there was 15 sessions without response. I would be thinking within 3 to 4 maximum. If that patient's not getting any better, the question needs to be asked, well, where are we going here? And I guess that could be, it's one of those examples of where the pathology, there is a pathology demonstrated on the imaging, but that pathology on that CT scan obviously wasn't what was driving that patient's pain. So I assume the neurologist's approach to managing the pain was more successful in the 15 sessions of physio. That doesn't surprise me, but it always disappoints me because it shouldn't get to 15 sessions. There are other presentations I didn't speak about today. I had one a few years ago where a patient, a 17-year-old boy, he had ankylosing spondylitis, and his story, when he comes in the door, he's a cricketer, he bowls, I'm thinking bone stress, but none of his tests fitted that pattern. And we sent him for the MRI, just hopefully to rule all that out. And it did rule it all out. He had a very inflammatory pattern as well. And it was led back to GP saying, please send this kid to a rheumatologist, please. And that's how that was managed. So we definitely need to be aware. I've tried to present what's most likely to walk in the door for you, but there is definitely a significant proportion of patients that will have imaging findings that aren't driving the symptoms that they've arrived with. And we do, I guess what you need in that situation is a team to work together, and you did the right thing, refer to physio, or the patient's already seen a physio, but it shouldn't have taken it, like the patient would have got what they needed in the end, but they've probably put up with more pain for longer than they needed to because it took longer to get to the solution that they needed. It shouldn't take 15 sessions to work out you're not winning. 2 or 3 and it should be like, okay, I've got to do something different here. I'd find those sessions really, really boring and humiliating to kind of keep doing them and not get anywhere. It's hard to convince a patient to come back sometimes when you're winning, let alone when you're not getting anywhere.
Yeah, No, I agree. I'm like coming from experience. I actually see Andrew and I'm like, I keep going, I get better, and then you go back, whatever it is. But yeah, no, I completely agree. So it's brilliant.
People vote with their feet ultimately.
Yeah, no. Well, thank you for that. I'm gonna stop the recording and then get into a few
Okay.
other things.